Okay, good afternoon to everyone. Welcome to this new PATHFAST webinar academy session, and thank you for joining us today. Today we are going to talk about Presepsin, the new reference biomarker for sepsis. It's a privilege to host you, and we are going to explore the clinical relevance of one of the most promising biomarkers in sepsis management, is Presepsin. Sepsis remains one of the leading causes of mortality worldwide, and early recognition is critical to improving outcomes. In this context, Presepsin has emerged as a key biomarker for both early diagnosis and prognosis of sepsis, offering clinicians rapid and reliable support in their decision making. It's my pleasure to introduce you Dr. Ashraf Tayar, a highly respected expert in acute and critical care. Dr. Ashraf is a consultant intensivist based in Egypt and also served as a consultant in acute medicine at King's Mill Hospital in United Kingdom. He has held senior leadership positions, including head of ICU, both at the Security Force Hospital at the King Fahd Military Medical Complex in Saudi Arabia. Internationally, Dr. Ashraf has been actively involved with the European Society of Intensive Care Medicine, where he has served as the Middle East representative and council member, and he is currently a task force member for critical care ultrasound. He is also in the program director of the Point of Care Ultrasound Fellowship offered by the World Institution of Critical Care and Emergency Medicine. And today he is going to be sharing with us valuable insights, clinical experience, and the latest evidence on the use of Presepsin in routine practice. His presentation will help us to better understand how this biomarker is shaping the future of sepsis care. I want to share brief notes before we begin. This session will run for approximately 60 minutes. Please feel free to write your questions in the question and answer box throughout the session, and we will address when the presentation is done for final discussion. With that, it's my pleasure to welcome Dr. Ashraf to guide us through this topic for today. Thank you again for being with us, and we are very much looking forward for your presentation. Dr. Ashraf, you can start. Thank you very much.
Thank you very much, Maria. It's my pleasure, and thank you for PATHFAST for inviting me for this meeting, which I will try to highlight some spotlights on the importance of the biomarker in general in reaching a fast diagnosis of sepsis, which, as mentioned by Maria, is one of the lethal conditions that we face and human beings are suffering from. The most famous and on the top list of mortality in human being, of course, as it's well known that there are three things that are very important in medicine. And the three words are the same: diagnosis, diagnosis, and diagnosis. So if you know the diagnosis, you would know the treatment. As Osler said, incorrect diagnosis leads to incorrect treatment. So it's very vital to know the diagnosis. Are you dealing with sepsis or you are not dealing with sepsis? Because when you know that you are dealing with sepsis, then you have to know that behind this is an infectious insult or agent that has to be treated with appropriately. So we use the antibiotics when they are needed to be used, and we use them appropriately in dosage, in terms of the frequencies and many other things, because it's well known that inappropriate treatment or antibiotics in sepsis is found in more than 30% of cases. So we may diagnose sepsis, we may know the organism, but we are not appropriate, and then you did nothing. The mortality is going to be there, and this is in around 30% of cases. So it's a very vital to know that your patient is suffering from sepsis and not from the mimics of sepsis. Not everything that present with fever, tachycardia, tachypnea are due to infection. And then if you know that there is infection behind the scenario you are dealing with, then you have to know that this sepsis might reach to the stage of disturbing the immune system response. This regulated immune system response is going to lead to multi-organ dysfunction and subsequently might be too late to save your patients. That's why the Surviving Sepsis campaign, in every series of recommendations and update, they are insisting on early recognition of sepsis and adequate antimicrobial therapy and source control, plus the fluid management. And there is, of course, golden hour. The first hour of presentation to ER or to ICU is very vital, that you have to reach a conclusion that what you are dealing with is most likely due to infection. And you do everything to narrow the differential diagnosis of your patient's presentation to know if you are dealing with infection or not. As I said before, not everything you see is infection. And time in ICU and emergency is life, because if the time passes without appropriate determination of what is going on is due to sepsis or not, then you lose patients. Every hour counts. We know from the several references that delaying giving the appropriate antibiotics 1 hour costs you increase in mortality by around 7%, especially in the first 6 hours of presentation. So every hour delay in giving the appropriate antibiotics will cost you 7% increase in mortality. And it's not only that you know that you are dealing with sepsis, but you know what kind of sepsis and what kind of antimicrobial you have to give. Otherwise, you lose, as I said, your patient. There are a lot of evidence of this, that delaying giving the appropriate antibiotics, i.e., delaying the diagnosis of sepsis, will cost patients' life. Why this is difficult? You might ask yourself, why I have to be confused if I'm dealing with signs and symptoms of sepsis? So I have patient who's presenting with fever, white cell count, high white cell count, chest X-ray of whatever finding, and presentation of cough, desaturation, shortness of breath, what I'm gonna wait for to diagnose chest infection. Or if I'm dealing with dysuria, frequency, plus the other previous signs that I mentioned, all they are pointing toward the infection, but these are not enough. There are a lot of uncertainties behind each of these signs and symptoms that your patient might present with. Let me give you an example of this. Fever. Not every fever you are encountering or patient encounter in ICU environment or ER is due to infection. In a matter of fact, around 50% of fever are due to non-infectious causes. It might be due to drugs, drug-induced fever. It might be due to trauma. Every trauma patient might present with fever without infection, and many other things. And you have to put in mind this fact, especially in ICU, because fever is very common in ICU, very common. And again, not every fever is due to infection. You wouldn't be surprised to know that even presence of indwelling catheters, either in the urinary bladder, Foley's catheter per se, central line per se, blood transfusion per se, tracheostomy, presence of endotracheal tube, any foreign body in the body might produce fever. Either this is a spike or even might be continuous, low-grade fever. Most of our ICU patients, they have this. And again, not all of them, they have fever, they have infection. There is radiologic uncertainty as well, because we see a lot of changes on the chest X-ray daily in ICU, or even our patients present to ER, or even in the floor with finding on the X-ray that might be white opacities. Not only every opacity is due to infection, even if there are other signs and symptoms of systemic inflammatory response syndrome. As we know, tachycardia, fever, tachypnea, and white cell count change, either leukocytosis or leukopenia, can all present in systemic inflammatory response syndrome due to whatever inciting agent, trauma, burn, postoperative, tubes, whatever it is. And this does not equal to infection. You call the SIRS, or systemic inflammatory response syndrome, infection only when you have evidence of infection, either bacterial, fungal, or viral infection. So there is radiologic uncertainty, especially in ICU. Even in the devastating presentation of ventilator-associated pneumonia, there are a lot of evidence that presence of virulent secretion is not 100% sensitive or specific. As I mentioned before, presence of leukocytosis is not equal to or a surrogate to infection. And also, as I mentioned, chest infection, even the sputum culture or even bronchoalveolar lavage might be colonization of the sputum and is not real infection. You have to put in mind that there is culture uncertainty as well. We know that up to 50% of the blood culture might be negative, even in bacteremic patients. The matter is, when you take this blood culture, from where you are taking this blood culture, how much sample you are taking to culture the blood. So around 50% of patients with bacteremia, they might present with negative blood culture. And this makes the diagnosis difficult if you rely on culture to prove that you have infection. 30% of the sputums, even in confirmed pneumonia, they turn to be negative culture in pneumonic patients. So the life is not that easy in ICU and in emergency. And even this applies to white cell count. You might have high white cell count, and this is at all is not specific to infection. So we see increase in white cell count due to many other things, like drug induced, like with convulsion, like with infarction, like with pulmonary embolism, postoperatively. With many things, you might see leukocytosis, and this doesn't mean that you are dealing with infection. So how can I shorten the differential diagnosis list to make the sepsis a top list of differential diagnosis, i.e. to reach final diagnosis of sepsis, you need something else, not the fever only, not the white cell count, not culture, not radiologic evidence, but we need something that reflects that there is an evidence of infectious agent, either bacterial, viral, or fungal, that initiated a body response to release something, and this something can be measured from the serum. This is what we call it biomarker. So we need biomarker actually to tell us that what we are dealing with in this clinical context or scenario is infection, fever, high white cell count, signs and symptoms of systemic inflammatory response, and then we send the culture waiting for the culture to come. It might take few days to have the culture results. Then if you see one of these biomarkers in the serum, this might tell you in a good sensitivity and specificity that what you are dealing with is likely due to infection. This is what we call it biomarker. There are a lot of biomarkers available. Most of them are for academic interest. around more than 170 biomarkers available, as this meta-analysis and systematic review showed. But there are other many meta-analyses that reflected the most commonly used biomarkers in the field of infection. The top list of these are procalcitonin, CRP, interleukin-6, and Presepsin. These are the most studied biomarkers, and especially the CRP, procalcitonin, interleukin-6, and Presepsin are available in the market in most of the countries. And the most studied biomarkers by evidence is in this list. Procalcitonin is the most one studied. There are a lot of literature on, and also Presepsin is highly and widely studied in the literature. You can find hundreds of papers to tell you about Presepsin sensitivity, specificity, the area under the curve, and comparison between the Presepsin and other biomarkers in field of critical care medicine and emergency medicine. Let me highlight some important points about Presepsin, especially in comparison to the widely used procalcitonin. And I'm going to try to show evidence that the Presepsin can be a good alternative to this and might be better than the others. As we know, when we have bacterial infection, and this bacteria attached to the cell surface of the monocytes and macrophages, the bacteria will be attached through the lipopolysaccharide binding protein to atoll receptors on the surface, and will initiate a process that results at the end of release of soluble CD14 into the circulation. This soluble CD14 is known as Presepsin. Normally, there is Presepsin in the circulation, minor Presepsin. Normally, with some other inciting agents like trauma or burn or whatever it is, might stimulate a little bit the surface and the process of the phagocytes to release the CD14, soluble CD14 or Presepsin into the circulation. But when you have bacterial infection, the synthesis and release of Presepsin will be significant in the serum. I'm going to come to this point later. But this is how the inciting agent, infectious agent, causes the Presepsin to be released into the circulation. As a process of the immune system fight, and as a step of the monocyte counterattack to the infection, the cells will release Presepsin, the soluble CD14. But it's not only specific to bacteria, but also if you have fungal infection, this will be also released. If you have viral infection, it will also be released into the circulation. If we compare here the Presepsin to the procalcitonin, procalcitonin is only for bacterial infection. So the cell, the thyroid gland cells, C cells, will release procalcitonin in response to bacterial infection. When you have bacterial infection, the procalcitonin level in the circulation will increase. But if you have fungal infection, this will be blunted. The response of the procalcitonin will be downgraded, and you wouldn't see much procalcitonin. And if you have viral infection, there is no at all effect on procalcitonin release. So you might have severe sepsis due to viral infection, and procalcitonin might be totally negative. It is with and against procalcitonin, as I'm going to come to this maybe later on. But again, when you have infection, the procalcitonin will be released into the Presepsin will be released in response to the infectious agent, and this is minorly affected by other non-infectious causes, So you might not see or see little effect of Presepsin if you have a non-infectious causes of systemic inflammatory response syndrome. And this, of course, the more you have Presepsin released into the circulation, the more you know you have to know that this is indicate a big burden of infectious agent on this patient. So I have a lot of infection. Severity of infection is indicated. And the more you have Presepsin in the circulation, the more you might know that you might be dealing with serious sepsis due to bacteremia and many other things. Presepsin is released into the circulation very early in sepsis process. And this is one of the big advantages of Presepsin, that once you have infection, either viral, bacterial, or fungal, you would see in your patient increase of Presepsin in 2 hours or less. So from 0 hour to 2 hours, the circulation will be reflecting the Presepsin, and you can measure it by a point of care machine bedside. This is very important because if you compare this to procalcitonin needs around 4 to 6 hours to show up in the serum. So a lot of difference. So you might have patient in ER presented to you after 2 hours or so, while in home, while transferred by ambulance, reaching your emergency department. And once you check his Presepsin, you might find it positive. While if you rely on procalcitonin, you might find it still negative. And you might be confused another 2 or 3 hours to identify with confidence if your patient is in sepsis or not. Procalcitonin or Presepsin reach the peak level in around 3 hours after the 2 hours. So in 5 hours from the presentation, you see the peak level of Presepsin. And this Presepsin half-life is another 4 to 5 hours from the start. If you count this, you started antimicrobial in ER once you diagnose that you might be dealing with sepsis. And then after 4 hours of starting the antimicrobial, you have to see that the Presepsin is started to decrease or not, because the half-life is only 4 to 5 hours. Presepsin is very well known nowadays in diagnosing sepsis, whatever the underlying etiology. There are a lot of evidence of this to diagnose sepsis in ER and in ICU. This is one of the systematic review and meta-analysis that showed that the area under the curve for the Presepsin to diagnose early sepsis in the first few hours of presentation is around 0.95, and this is very high. It means that the probability of when you see Presepsin in the circulation, when you measure the Presepsin and the samples come positive, there is a very high probability reaching up to 1 that the only differential diagnosis here is sepsis, i.e., when you see patient with signs and symptoms of systemic inflammatory response and you are still confused if this is due to infection or not, and you see the Presepsin, very high probability that this is due to actual infection. The importance of this, that I may rely on to start my appropriate antibiotics. This is highly needed in ICU. As I mentioned before, our life in ICU is not easy because a lot of things confuse the presentation and makes the differential diagnosis very wide. As I mentioned, in CAUTI, in VAB, in VTE, ventilator-associated events, tracheobronchitis, central line-related bloodstream infections, many other things that I may need to know before I add another antibiotics or not. I need to know if I'm dealing with infection or not. Presepsin was found to be very good with sensitivity and specificity above 80% if you are dealing with community-acquired pneumonia or not, early in ER or in ICU. The specificity is high and the sensitivity is high. The positive predictive value is above 90%. And especially if you add Presepsin to other biomarkers like PCT, the specificity increases more and more. I.e., again, when you have procalcitonin positive in your ICU patients and the Presepsin was also positive, there is a positive predictive value of more than 97%. And this is, believe me, is very important in ICU because it lightens the decision to know if you have to start antibiotics or not. If you use Presepsin in the community-acquired pneumonia to know the survival possibility or probability, it's also very valuable and very significant. In non-survivors, the Presepsin increases very significantly compared to the survivor. Even so, in ERDS patient, and this is very common in ICU, we may face cases that patient develop ERDS, especially in trauma patients, and we don't know if this is due to lung contusion, due to trauma, chest trauma, or due to burn or whatever it is, or due to sepsis-related ERDS, bacterial or other infectious ERDS, super added infection on top of trauma patients or not. Presepsin can differentiate between sepsis-related ERDS and non-sepsis-related ERDS. And again, on those type of patients, the survivors had lower Presepsin level compared to non-survivors. Not only that, but also in abdominal surgeries, post-abdominal surgery infection. Post-abdominal surgery infection is very common. And we would know if there is infection complication, post-abdominal surgery, if you follow your patients with Presepsin, and it was found to be even better in reflecting the infection earlier than the procalcitonin, and so far earlier if you rely on the other alternatives, which are white cell count, CRP, changes in lactate, changes in blood gases, or whatever is parameters you are used in post-operative patients. It's very important to know that. Very important to know that you need a biomarker in your patients, either in ICU or in ED, to narrow the differential diagnosis, to know if your patients in ICU complicated with infection or not. And the discriminating point here between the two famous biomarkers, which is procalcitonin and Presepsin, is the first and faster availability in the serum. The Presepsin preceded by few hours the procalcitonin and shows up in the circulation. In ER, maybe the problem is more even complicated, because in ER, a lot of things might be yet not cooked well, and you don't know where is your patient is going to. You need to reach diagnosis of infection or infection-like diseases before you start the antibiotics. You need to have rationale for giving antibiotics, because there are a lot of restrictions on use of antibiotics. If you are in ER and you have a patient who is presenting with signs and symptoms of sepsis, but yet not to have evidence that this is because of infection, Presepsin can help you, especially in ER, because as I said, it releases very early in the circulation. The time of patient's presentation to ER is the time when the Presepsin started to be released in the circulation. The area under the curve, which is again reflect the probability percentage of this test, is positive to reflect the presence of the disease. This is what we mean by area under the curve. And the more the area under the curve is above 0.5, and the more it reach around 1, the more it indicates that it is with good sensitivity and specificity. The Presepsin, when it was compared with medical score system, Apache 2, SOFA score, whatever is, was found to be very good marker to indicate presence of sepsis in ER patients. Not only that, but also to triage your patients, those who present to ER with sepsis and very high Presepsin level. If the Presepsin level in ER is more than 825, as this presentation, this paper is showing, the more it is above 800 plus picogram per mil, the more it indicates a higher mortality. And the more it indicates that you have to put more focus on this type of patients, that they have to be tackled early, giving them antibiotics early in the golden hour in ER, taking them to ICU if needed early, giving them fluid resuscitation. And the more important is try to find where is the source of this infection, because the source control is very important, not less important than the giving the antibiotics. Both of them are very important, and the earlier the better, and the time is life. There are a lot of evidence of this, that post-operative infection in children can be tackled and diagnosed early if we rely on Presepsin. And this is again was compared to procalcitonin. As you see here, the area under the curve or the row curve of Presepsin in day one, post-operatively in children, was found to be with a very high area under the curve and far away better than day one procalcitonin level. So relying on Presepsin day one or day three was found to be much, much better compared to the procalcitonin in diagnosing infection in post-operatively in children. Not only that, but also if my unit is dealing with burn patients, they might present with all signs and symptoms of sepsis. And we wonder all of the time, if my patient with burn, who is now feverish, tachycardic, tachypneic, and white cell count is sky high, started to acquire infection or not, which is very common. If you rely on procalcitonin, for example, the blue colored here, the light blue colored here, as you see, it takes maybe 14 or 15 hours to show significantly in the circulation. While if you see the Presepsin, which is brown here, is started in around 4 hours or less to show significantly in the circulation. So burn patients that you suspect infection and you do Presepsin very early, you can pick them and you can start the appropriate antibiotics. Not only that, but also invasive fungal infection, which is very common, lethal complications in critically ill patients, and very confusing for the frontliner intensivist to suspect it or when to start the antifungal. You need 1 and 3 beta D-glucan, or Mannan antigen, or anti-Mannan antibodies, or you need culture, and all of them, though they are high in yielding, but they take time, and their availability bedside is absolutely difficult. And a lot of hospitals, they don't have these facilities. Presepsin, which is in point of care machines that can be available bedside in your unit in the ICU or in ER, and I'm talking from the clinical experience, that Presepsin bedside, like you do the troponin, like you do the blood gas, like you do the lactate, and you can pick up the cases that in your unit and started to complicate and deteriorate, and you suspect it because they're high risk of fungal infection. If you see the Presepsin, though it was stabilized, now increased, jumped up, this reflects infection with high diagnostic accuracy. If I just kindly remind you, ladies and gentlemen, what I said about procalcitonin in fungal infection, that it rather go down with the fungal infection, doesn't go up. So procalcitonin will miss the fungal infection, while the Presepsin is very good to detect so early the fungal infection complications on top of bacterial or viral infection, like in COVID, like in immune compromised patients, like in patient with risk factor for fungal infection. If you suspect this and you want to confirm, and you have the antibiotics on board, day 3, day 4, your patients start to febrile again, white cell count start to increase again. You wonder if this is due to bacterial deterioration or not, or this is due to fungal infection because I have high-risk patients. If the Presepsin was stabilized previously and now goes up, this will reflect high possibility of fungal infection. There are a lot of protocols on this. If you see normal procalcitonin or normal Presepsin, usually you don't have sepsis in more than 90%. Normal procalcitonin or mildly increased procalcitonin, they might be due to suspected, they might be there a fungal infection. And here, on this type of patients, the Presepsin will be very high. Procalcitonin very high, Presepsin very high. This will indicate bacterial infection or mixed type of infection if you are going with Presepsin. But if you are using only procalcitonin, you might miss the diagnosis of fungal infection. So it's again, which one I go with, Presepsin or procalcitonin? As I mentioned, procalcitonin takes time to show in the circulation, takes time to reach the peak level, and takes time to decrease in response to bacterial infection treatment. And there are a lot, to be very frank, there are a lot of evidence that the procalcitonin is very good in guiding the antibiotic therapy, when to initiate it. When you have decrease of the peak of procalcitonin to more than 80%, you can stop the antibiotics. You know that you are appropriate if you have a marked decrease of procalcitonin from the peak, which is around 18 hours from the starting the antimicrobial. If you have decrease of more than 50%, you know that you are appropriate. But when the procalcitonin was compared to Presepsin in diagnosis in ICU, the procalcitonin and CRP was found to be less compared to Presepsin based on the early detection of Presepsin. There are a lot of evidence to show the preference and the level of superiority of the Presepsin when it was compared to the procalcitonin and CRP in terms of diagnosis, reaching the diagnosis early, in terms of picking up complicated infections post-operatively, and picking up the fungal infection. And don't you think if you detect early the infection or sepsis, particularly in immune-compromised patients, particularly not to miss the fungal infection, particularly to know if you are using appropriate antibiotics or not, this all will impact positively on mortality and outcome. And as I mentioned before, you have to know very clearly that the procalcitonin, this appointing point against it is the time response to the infection. It takes time. And the time response to show up in the circulation after starting the antibiotics might take up to 1 day to show up. The decrease of procalcitonin, a day in ICU is too much. To wait a day when you started antimicrobial and you know or you don't know that what you selected as antibiotic is appropriate or not, to wait hours that might reach up to 24 hours as this evidence is showing. 24 hours is too much for knowing if you are dealing with appropriate antibiotics or not, i.e., if you are having bacteremia and it's a gram-negative, as the gram staining showed, and you started cefepime, for example, but the cefepime was not appropriate, and you went and sleep waiting for 24 hours. If you compare Presepsin here, and you started the cefepime, you follow up your patient, within 6 hours from starting the antibiotics, Presepsin will show response to decrease. while within 18 to 24 hours, the procalcitonin will show the response. Both of them are not different in day 3 onward. So day 1, Presepsin is preferred than the procalcitonin. Day 2 still. From day 3 onward, both of them are equal to follow up your patients. This is very critical. Few hours, not only 24 hours, makes a huge difference in outcome. Another meta-analysis and systematic review that compared procalcitonin to the Presepsin. Both of them in critically ill patients to back up the infection was with almost the same sensitivity and specificity, but again, put in mind the kinetics of both. And there are a lot of recent evidence, like this one was published in Shock Journal or Journal of Intensive Care, recently showed that there is no, at the end of the day, difference between the Presepsin and procalcitonin in predicting the bacteremia, in diagnosing the bacteremia. But there was a significant evidence to show the preference for Presepsin if you want to know the appropriateness and you reach diagnosis earlier. What about if you combine both of them, procalcitonin and Presepsin? The evidence showed that combination of both was found to have more sensitivity, so less false negative, and more specificity, so less false positive, and the positive predictive value is more positive, more percentage if you combine both of them. If you combine the Presepsin or procalcitonin to the SOFA score, Apache score, the yielding of either of them will be also higher. Risk stratification and prognosis is also very important. It's very important to know if you are dealing with patients whose highly likelihood of mortality is higher or less to die. It's very important because the action has to be more appropriate, more faster, and you attack earlier if you are dealing with high risk to die. Presepsin was found to be very good in predicting those who are very high risk to die compared to those who are less risk to die. The survivors of sepsis presented to ER or in ICU, they have less Presepsin response, less Presepsin in the serum compared to non-survivors. The dead patients, the dying patients will have more Presepsin, and this is as compared to the other biomarkers was found to be very obvious that the mortality in higher Presepsin was higher in non-survivor compared to survivor. We did a study, myself and my team, in patients presented to ER and then to ICU with suspected mortality. And we found that Presepsin compared to the quick SOFA and compared to systemic inflammatory response signs to predict the diagnosis of sepsis. So we have the patient with suspected sepsis. We did the quick SOFA score. We did the systemic inflammatory response criteria, and we predicted if they have sepsis or not. And we predicted also if they're gonna die, the probability of death on this patient or not. Presepsin was the best among these chosen variables to show the diagnosis of sepsis and to predict the mortality. And the Presepsin behaved better when it was compared, the quick SOFA behaved better when it was combined to sepsis, to the Presepsin. And the Sears criteria behaves better when it was added to Presepsin. So you may rely on Presepsin alone. If you are a fan of using the scoring system, then the scoring system per se is not enough to predict mortality or to predict the diagnosis. It's not enough at all. If you add to this the evaluation scores or this whatever score you use, if you add to this Presepsin, we found that the yielding or finding was much higher positive, and this was published 2 years ago. Also, Presepsin was found to predict patient in sepsis if they're going to develop multi-organ dysfunction or not. The more the Presepsin in the ICU patients with presentation of sepsis, the more they have Presepsin level on the serum in day 1, 2, or onward, the more they are at high risk to develop multi-organ dysfunction, and the more they have probability to die. And the Presepsin, especially early, when it was compared to procalcitonin in this trial, which is known in this literature as ALBUS trial, or albumin Italian outcome sepsis trial, the Presepsin was better compared to procalcitonin to predict the outcome in those type of patients, particularly, as I mentioned before, early in the course of sepsis. This is very important, as well as in mortality, the 28 days mortality. So using Presepsin can stratify the risk of your ICU patients, can lead to better prediction of multi-organ dysfunction syndrome as a matter of number of the organs, dysfunction, and the severity of this dysfunction, as well as the mortality, of course. There are a lot of evidence on this. There are a lot of evidence to compare the Presepsin to procalcitonin, the Presepsin to Quicksilver, the Presepsin alone or combined with Quicksilver, or the Quicksilver in combination with procalcitonin. And all of this evidence show that the Presepsin alone or in combination is better than procalcitonin alone or in combination with medical scoring system. Do we have any therapeutic implications if using the Presepsin in our patients in ICU or 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 ER or any acute care setting? Definitely yes. If you use Presepsin to diagnose sepsis, then your patient, if has a parameter of Presepsin less than 500 picogram per ml, and some reference says 600, this might be unlikely to have sepsis, particularly if this number is less than 300, with a sensitivity and specificity very high, more than 87%. If I'm dealing with SIRS criteria and Presepsin is less than or equal to 500 to 300, unlikely, less than 300, very unlikely. On the other hand, SIRS criteria with a Presepsin more than 600 to less than 1,000 picogram per ml, then it's a very high likelihood, significant risk of systemic infection. And the more it goes above 1,000, the more you have to suspect very high load of bacterial or viral or fungal infection, and a very high possibility that you are dealing with bacteremia, and very high likelihood that you are dealing with at high risk of mortality patients. This is very important in early triaging of your patient, either in ER or in ICU. Another very well-known potential as a therapeutic implication of using the biomarker in general and Presepsin in particular, as I mentioned before, that you suspected and diagnosed sepsis, you started the antibiotics, or even if negative Presepsin, you might hold to start antibiotics. Then you save using inappropriately or unnecessarily antibiotics. You save the antibiotics, so you reduce the risk of antibiotic resistance. You reduce the cost. You reduce the length of stay. No, I'm dealing with infection. Presepsin is positive. I gave the appropriate antibiotic as I believed. Then I follow the Presepsin. If I see it decreasing within 4 hours to 6 hours from starting the diagnosis and starting the appropriate antibiotics, Otherwise, you escalate the antibiotics to double coverage, or you change the group of antibiotics to a higher group of antibiotics to be more appropriate, and then you follow the Presepsin. Within the first few hours, up to 24 hours, in the first day, you would know, and you put the map, very appropriate and great, accurate map for your patient to go in the correct pathway. Of course, therapeutic implication that you know if you use the antibiotics as it's needed appropriately, and then also the appropriate time interval. Because a common mistake we see that we put antibiotic and we forget the duration of antibiotics. Ladies and gentlemen, 7 days compared to 14 days of antimicrobial was found to have no difference if you are giving the appropriate antibiotics. So why you go with 14 days if you can stop by day 7 or even by day 5 your antibiotics? If you see clinical response and you see the biomarker, if you are using Presepsin, by day 5, reduce to near to zero or near to negative, you stop the antibiotics. There is very important point here that favor the Presepsin, that the initial response of your patients, either in ER or in ICU, you may give appropriate antibiotic. You may start to see initial clinical response and laboratory response. So you see white cell count decrease, fever decreases, but your bacteria started to develop resistance, and will take few days to show up clinically in your patients. So day 3 or day 4, everything is nice, fine. Procalcitonin will reduce, but the Presepsin will never reduce. If your bacteria is not responding in very nice way, and it can smell the Presepsin and predict if the bacteria is turned to be active so earlier than the other parameters. So the Presepsin will never reduce to below normal or normal if the antibiotic is not working appropriately and efficiently. Ladies and gentlemen, if I have to recap, I would say that biomarkers are very important and very, in my opinion, based on researches and based on our clinical bedside experience, they are highly needed in ICU. If you are dealing with infection suspicion and you have this biomarker repeatedly to be negative, very unlikely to have bacterial infection. Add to this viral and fungal infection if you are using Presepsin. They are very highly sensitive and specific. You can start antibiotics and follow up your patients based on the biomarkers in general. Presepsin is found to be better than procalcitonin in following up the early picking up of complications. Presepsin is very promising and in need a very focused attention to reach early diagnosis of infection in children and in neonates, and there are a lot of evidence of this, and to reach fast diagnosis before the other parameters are gonna be positive in the circulation. They need a very simple maneuvers, bedside point of care machines to detect it in few minutes, and you would know if your patient is dealing with serious infection in general or not. Hopefully I covered everything you wish to hear, and by here I thank you very much for this. I'm ready for your questions.
Thank you very much, Dr. Ashraf, for this insightful and very interesting presentation, where you've provided us with a deeper understanding of the clinical value of Presepsin in sepsis diagnosis and also in prognosis, and how this biomarker can truly support faster and more confident decision making in acute care. Now we would like to open the time for questions. You have a question and answer box. If you want to state your questions there, we can discuss with Dr. Ashraf. While we wait for the questions from the attendees, Dr. Ashraf, I would like to ask you something. We have been seeing the information in your presentation, and we have seen that sepsis is a very complicated and severe situation, and the combination of several biomarkers is always valuable. Considering the variety of biomarkers available, what would your ideal diagnostic panel for sepsis include?
Yeah, this is a very good question. To start with, there is nothing in this life is 100% perfect. And as we used to say in everything, that your patient has to be a puzzle-like management. So you have puzzles. The history is one of the puzzle, the clinical presentation, and the behavior of your patient bedside, plus the biomarkers. So if I have patient who is presenting to me either in ER or in any acute care facility, including ICU, and they have fever, white cell count, and the other parameters of systemic inflammatory response syndrome, the history might be deceiving. Not every patient who is feverish and coughing having pneumonia. They might be connective tissue disease. They might be interstitial lung disease. Not every patient who is having dysuria and frequency, fever, white cell count, they have UTI. The problem here is that you need something to reflect that there was infectious agent in this patient system that led to this organization of the immune system, and that led to that the fighting cells, which is the white cell macrophages, responded to this infection by releasing something that reflect that there was bacteria here. If I have something puzzle like this, would I use it or not? To narrow the differential diagnosis. And the very important point here, which we base on to defend using the biomarkers in general, which is if I use the antibiotics for everyone, I'm suspecting them they have infection. Then we're gonna be messed with a lot of bacteria resistant bugs, a lot of new bugs, but no new drugs. We have a lot of resistant bugs nowadays, and this is because of the abuse of antibiotics. If I use the antibiotics only for those who are having evidence of infection, and what could be the strong evidence of infection is the culture. So I have somebody who is presenting with fever and signs and symptoms of sepsis, and then I culture their sputum, and I found organism. Yeah, there is here a high probability of pneumonia, but it's not 100%. You know what is 100% evidence of pneumonia? Is to culture the tissue of the lung which is infected. So you go through the lung and you take a biopsy and you put it under the microscope and you see that there is evidence of pneumonia, and this is because of this organism. So am I going to do for every pneumonia suspected lung biopsy to give antibiotics or not? Or may I leave my patient to suffer few hours, suffering few hours or even days till I have culture that may take 2 to 3 days. Sputum culture takes 2 to 3 days. And if the bacterial, the blood culture might take up to 5 days. And in low-income countries, it takes up to 7 days to know if your bacteria is there in the blood or not. This is devastating time. You might have the patient die before you know if they're dealing with infection or not. Again, back to the golden statement, which is not every SIRS is infection, and not every SIRS needs antibiotics. You have to know early, and you have not to throw the antibiotics for everything you suspect. Otherwise, you are in a very difficult situation to give or not to give antibiotics. Use the biomarker. Can facilitate this for you. At least you buy 2-3 days giving the antibiotics before you delay giving the antibiotics. This is, in my mind, in my opinion, is very vital piece of information.
Thank you so much for your comments. We do have some questions in the chat now. So we have here, thank you for your insightful presentation. Based on your clinical experience, could you please elaborate on the optimal frequency of Presepsin testing in the emergency room and the ICU settings, particularly in terms of balancing early detection with monitoring treatment response?
Very, very good question. Respecting and knowing the kinetics of the Presepsin, the Presepsin releases very early into the circulation of infected patients. So within 2 hours of the inciting agent attacking the patient, bacteria or viral or fungal, the Presepsin will start to show in the circulation. Within the 4 hours, early 4 hours, this Presepsin will reach the maximum level. So in 6 hours of patient's presentation, by the way, this might be at home. So your patient started to be feverish and presented to you after 6 hours of fever to ER. And here, definitely in ER, you would see Presepsin positive. Then you start the antibiotics. Give the antibiotics another 6 hours and check the Presepsin again. In the next 6 hours, which is 12 hours from the starting the infection, 6 hours from the giving of the antibiotics, and then measure the level again. If it decreases by more than 50%. So, for example, I have patient, Presepsin first level was 800. I gave the antibiotics, whatever the antibiotic. I diagnosed UTI, I gave levofloxacin or ciprofloxacin, any of the quinolones. Then I check the clinical response. The clinical response might take up to several hours more or even day to respond. The dysuria, fever, and white cell count takes day or two. But the Presepsin takes 6 hours to show significant reduction. So another 6 hours, so do 0 level. When the patient presents to you, order it. Give the antibiotics 6 hours from the antibiotics, do the Presepsin again. Then you might repeat it 12 hours from this, 18 hours. Here, you have to have evidence that the reduction of the Presepsin is continuing to drop down. And you might reach by day 1 the normal level of the Presepsin. This will be very assuring. If you compare this to procalcitonin, we do it every 8 hours. And it might take 2 days to reduce more than 50%. And you never know between day 1 and day 3 if this is because of the delay response or because of the complications or because of inappropriate use of antibiotics. Presepsin gives you this advantage. So 0 hour, 6 hours later, 12 hours later, then you do the Presepsin daily and in case of any deterioration. For example, if I'm dealing with immune compromised patients, febrile neutropenia, started the antibiotics, Presepsin reduces, and then a super added fungal infection happened in day 2 or day 3. I started to see the hemodynamics deteriorated, the lactate increases, the score deteriorated, and I suspected super added bacterial fungal infection. Check the Presepsin here. If it goes up, this indicates that if you are dealing with high-risk patients of fungal infection, to add imperative antifungal treatment.
Thank you very much. We have another comment. Is there a particular value of Presepsin that may differentiate bacterial, viral, or fungal sepsis?
Yeah, another good infection, a good question. In the 3 causative agent of infection, bacterial, viral, or fungal, the Presepsin will increase. But it was found that in bacterial infection, the Presepsin level is the highest expected level. In gram-negative, it's higher than the gram-positive. In bacteremia, it will be higher than the non-bacteremic patient in fungal infection. In viral infection, the Presepsin will be positive as well. So in COVID patients, we see Presepsin high. but is not expected to be as high as in bacterial infection. In fungal infection, it goes very high, also very significantly. If you compare this to procalcitonin, viral infection attenuate the procalcitonin. So if you have viral infection, there will be no procalcitonin at all. And you wouldn't know if you are dealing with infection or not infection. PCT increases with bacterial infection significantly after few hours of infection. Procalcitonin will be reduced by fungal infection. So it attenuates the response. The fungal infection attenuate the response, and the procalcitonin will reduce, will not be high. In viral infection, it has no effect on the procalcitonin at all.
Okay, thank you. And we have another question. They are asking about reference values for children.
Yeah, good question again. In adult, which is my focus of interest, the Presepsin, when it is above 600, is with very high specificity and very high sensitivity of bacteria, of infection in general. In neonates, it's a very variable. It tends to be maybe at the same or even higher. So there is no, one of the drawbacks of Presepsin, like in procalcitonin, that there is no definitive 100% accurate level for the Presepsin to point out the infection. There is agreement on the 600 in most of the literature, 600 picogram per ml, but there is no consensus on this. And the absence of consensus, in my best of knowledge, is more in children and in neonates. But you can take the cutoff point still of 600 for pediatric and in neonates, for best of my knowledge.
Okay, thank you very much. Any more questions that you would like to state to Dr. Ashraf? We have a comment here. They are asking if we have to present this biomarker to a hospital administration to support the implementation of Presepsin testing, what key clinical or operational arguments would you highlight to justify its inclusion?
Yeah, what I did is when I meet with the hospital administration and tell them, I will show you my local ecology, my local microbial evidence in my hospital. See how much resistance do I have and how much resistance bugs I have with no drugs. Bad bugs with no drugs, Acinetobacter, multi-drug resistant gram-negative, including ESBL, including KBC, including this and that. And everyone in this world knows that the first and the most important risk factor for resistance is the abuse of antimicrobial. I'm going to tell my administration, I'm dealing with patients who are really confusing. And we are in an environment that is not at all very certain. So we have a lot of patients who present with signs and symptoms of sepsis, but at the end of the 3 or 5 days waiting for the culture and waiting for them to show up is too much time to start empiric antibiotics. So what if I can have something to rely on with a possibility that more than 80% I might be right in deciding to give or not to give the antibiotics. More than 80%, I'm going to be accurate. So I'm dealing with the signs and symptoms of sepsis in this environment of ICU or ER. Should I use antibiotics for all of them? And should I use the big guns from the beginning, which the situation deserves? Or should I wait and I may lose my patients? or should I use a biomarker with evidence that they might help in reaching earlier the diagnosis? Not only reaching the diagnosis, but only also allows you to know if you are using the appropriate antibiotics and to shorten the duration of antibiotics. So diagnosis, knowing to start or not to start antibiotics, knowing if I'm appropriate or not, knowing to give more than one drug or not, knowing to give shorter duration of antibiotics or not, and show them the evidence when this school of management led to shorter ICU stay, shorter duration of antimicrobial, less antimicrobial resistance, less cost, and the most important is less mortality. If you have these advantages and you have point of care machines that are bedside, cost-wise, when you compare to the cost of mortality and cost of abusing antibiotics and cost of having multi-drug resistant bacteria, the cost of this or the cost of using a test that might cost few dollars in my patients, hundreds of dollars, thousands of dollars, costing life or costing this minimal amount of money. Of course, any administration will be convinced, but you have to be ready with evidence, and you are the front liner. You have to fight for what you believe that is going to help your patient. Thank you.
Thank you very much. I totally agree. And well, we have seen that there are many key points and advantages in the use of this biomarker. And as Dr. Ashraf stated, not alone, but in combination with medical scores, other biomarkers, we are going to have a powerful diagnostic. So, well, we are running out of time now. So thank you everyone who joined us today, and especially Dr. Ashraf for sharing such valuable insights and clinical experience with us. We will be sharing the recording to all the registered people. And well, thank you very much to everyone, and we hope to see you in our next PATHFAST webinar academy session. Thank you so much and have a nice evening.
Thank you very much.